Ma'am, we are on live, ma'am. Shall we start,
Yeah.
ma'am?
Yeah.
So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Health, welcoming you all for today's webinar. The topic for today's session is current trends in endometriosis. I welcome all the participants. I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. Now, it's time to introduce our invited speaker for the day, Dr. Anitha Thanasekaran, ma'am. Madam has done her MD and DGO. Madam is currently the consultant at Team Hospital, Pudukkottai. So, with this short introduction, I welcome you, ma'am, to share your activity. Over to you, ma'am.
Thank you. Thank you so much. First of all, I thank Shield Healthcare for giving me this opportunity to talk about endometriosis.
Your video is not.
Yeah, I'm going to start.
Yeah.
Wait. Yeah. I thank you. Once again, I thank you, this Shield Healthcare, for giving me this opportunity to talk about endometriosis. I am Dr. Anitha Thanasekaran, consultant physician, Team Specialty Hospital, Pudukkottai. Just a minute. Hello, welcome everybody. I am Dr. Anitha Thanasekaran, consultant physician, Team Specialty Hospital, Pudukkottai. Today, I'm going to talk about the current trends in endometriosis. Endometriosis, as you all know, it is an enigma.
Ma'am, sorry,
Yeah.
ma'am. The
Yeah.
screen is not displayed, ma'am. The PPT is not visible, ma'am.
It's that?
No, ma'am.
It's not that?
No.
Wait. Wait just a minute.
Yeah,
First,
ma'am.
it was that. Are you able to see it?
Yeah, ma'am. Now it is fine.
Yeah. Endometriosis, as you all know, it is an enigma. The mystery cannot be revealed within an hour. I'm just going to tell an overview about endometriosis. So as to say, I'm just going to give a bird's eye view about endometriosis. Endometriosis, it is one of the most common gynecological conditions which nowadays we encounter in our OPDs. It is aptly described as a benign condition in which the endometrial glands in the stroma, they are present outside the uterine cavity and the wall. Important is that these endometrial glands and stroma, they are hormone dependent. Why is it makes it so important to understand endometriosis? Its importance is due to its distressing symptomatology. There are so many symptoms. There is not a single symptom for which the woman comes to OPD. These symptoms are such distressing to her that it affects even her daily life. The other important thing about endometriosis is that it is most commonly associated with infertility. The potential of these endometrial tissues to invade the adjacent organs, behaving like cancer, makes it more important to understand its pathology. Above all, the most important thing is its difficulty in being diagnosed. We cannot easily diagnose endometriosis as such. So, hence, this makes one to know about endometriosis properly. Coming to the endometriosis, as I have said, it is one of the most common conditions encountered in gynec practice, and the incidence is nowadays on rise. Nowadays, we are able to see more of scar endometriosis. It is estimated that 5 to 15% of women, they have some degree of the disease, which is noted in women who are undergoing gynecological laparotomies for other procedures, even for other procedures. It is an unexpected finding in 50% of these cases. And major studies nowadays have reported that 25 to 30% of infertile women, they have endometriosis. And also 35 to 50% of women with endometriosis are infertile. The true prevalence of endometriosis is difficult to quantify, as very wide ranges have been reported in the literature. Endometriosis is found in about 45 to 82% of women who complain of chronic pelvic pain. Among these, 1/3 of these women, they have visualized endometriosis. Such is the magnitude of endometriosis. Coming to the age of occurrence, it classically presents in nulliparous infertile women in their 30s. However, nowadays we are able to see endometriosis even in children and in adolescents. In these people, it is most commonly associated with obstructive genital anomalies. Following menopause, it usually regresses. But when we give estrogen as HRT for these women, 5% of new cases can develop in that age group. So endometriosis can be seen in all age group, although its preference is more in their 30s. Coming to this pathogenesis. The disease is a complex one, and the pathogenesis is still not fully understood. And endometriosis does not occur in every woman as such. Only if this woman, she is genetically predisposed and she has immunological changes in her body that are conducive to develop endometriosis, then she gets endometriosis. For this, several theories have been hypothesized to explain the various manifestations of the disease. The various theories which we have already read in our book, but still it holds good. And this comes the retrograde menstruation theory, the Mullerian metaplasia theory. Next is the lymphatic spread theory and the hematogenous spread theory. Coming to the retrograde menstruation theory, it proposes that the endometrial fragments that are shed during menstruation, they are transported through the fallopian tubes, and then these become implanted and grow in various intra-abdominal sites. Important is that these endometrial fragments, they are viable and they are capable of growing both in vivo and in vitro. This theory is supposed by the anatomic distribution of the implants of endometriotic tissue, but it does not explain why endometriosis is present in only 10% of patients, even though reflex menstruation is present in most of the menstruating women. Next comes the Mullerian metaplasia theory. It proposes that this endometriosis results from the metaplastic transformation of this peritoneal mesothelium to endometrium because of the influence of certain unidentified stimuli. Coming to the next theory, which is the lymphatic spread theory, it suggests the lymphatics which drain the uterus, they transport the endometrial tissue to various pelvic sites where it grows ectopically. We are able to demonstrate endometrial tissue in up to 20% of patients with the disease. The hematogenous spread theory, they explain the presence of endometrial tissue in distant sites, such as lung, axilla, even forehead. In a nutshell, this picture depicts a woman who is genetically prone and who has immunological changes and whose environment is conducive for development of endometriosis. Here, in these women, maybe the Mullerian risks have been induced to develop endometrial tissue, or the mesothelium may undergo metaplasia to develop endometrial tissue, or this endometrium, which is shed during menstruation, by cell reflux may be transported. Even in the bone marrow, the mesenchymal the hematopoietic stem cells, and even endothelial precursors, they can be transformed into endometrial tissue. These endometrial tissue may be transported to distant sites either by the lymphatic spread or by the hematogenous spread. This explains the pathogenesis in a nutshell. Coming to the sites of occurrence, as we all know, it is most commonly found in the dependent portions of the pelvis. Ovaries, we all know, it is most commonly affected. And 2 out of 3 women with endometriosis have involvement of the ovaries. Next comes the broad ligament, the peritoneal surface of the cul-de-sac, that gets involved. Laparotomy scars, we can see this mass of endometrial tissue, tender mass after C-section or myomectomy, or whenever surgery has been done where the uterine cavity has been entered. So nowadays the scar endometriosis is on rise, and we are able to diagnose and treat them. What are the symptoms with which the women present to you? There are more number of symptoms, and the symptoms are variable. Unless you have high index of suspicion, we will never diagnose endometriosis. Hence, there is usually delay of many years between the onset of symptoms and for the definitive diagnosis. By the time the disease would have progressed. Now we'll see the commonest symptoms with which the women present to you. Most commonest is the severe dysmenorrhea. She can present with deep dyspareunia. She can have chronic pelvic pain. She may suffer from ovulation pain. She can have perimenstrual pain or bleed. Most of the time she is infertile. Chronic fatigue is one of the symptoms we usually overlook. We'll see it as anemia, and we'll look for other diseases rather than diagnosing endometriosis. Pain during defecation is also commonly present. About the pathology, as I already said about the various theories, the one common thing is that these islands of endometriosis, they are sensitive to ovarian hormones. Among the hormones, the estrogen, it causes proliferation. It can be proved by the regression of corpus luteum when there is removal of estrogen and progesterone. When there is removal of estrogen and progesterone, it causes this endometriotic tissue to slough out. These sloughed debris, then they induce a profound inflammatory response. This inflammatory response is responsible for causing significant pain and long-term fibrosis and adhesions. So it is the basic pathology of affection of endometriosis. We all know we can see endometriotic lesions whenever we do a laparoscopy or laparotomy, even for any other procedures, any other surgical procedures. So we need to know how does these lesions look like. The macroscopic appearance, most commonly, it depends on the site, the size, the time since implantation, which gives the color, and the day of the menstrual cycle. The color, it is a good indicator. It is determined by the vascularity of the lesion, the presence of fibrosis, the size of the lesion, and the presence of residual sloughed material. So the color can vary from red, brown, black to white or yellow. The newer implants usually are red, and they are blood-filled active lesions. The older lesions, they appear white to yellow because of scarring, and they with a puckered appearance. So only if your mind knows that you will see. So having this known about this macroscopic appearance, what we have to do next? We have to send this endometrial tissue for biopsy. And if you are able to demonstrate endometrial epithelium, endometrial glands, or endometrial stroma, or hemosiderin-laden macrophages, then we can confirm the diagnosis of endometriosis. 2 out of 4, these things must be present in the biopsied specimen to confirm. A word about this endometriosis of the ovary, which is a very commonest finding, and we all know it as chocolate cyst of the ovary. These are cysts which are filled with thick chocolate colored fluid. Sometimes these may appear as black tarry. This characteristic fluid, it represents the aged hemolyzed blood and the desquamated epithelium. When these gets collected in the cyst, the glands of the stroma which line the cyst wall, they may be destroyed due to an increase in pressure. This leaves behind a fibrotic wall with infiltrating hemosiderin-laden macrophages. Then they get adherent. Even the kissing ovaries are seen because of this fibrosis. Who are all the women who are at risk for developing endometriosis? The nulliparous, the infertile women, the women in the reproductive age group, usually late teens to 40s. If a woman whose first degree relatives suffer from endometriosis, she is also at risk in developing endometriosis. If a woman whose regular menstrual cycle, she has regular menstrual cycle, but if it is less than 27 days, or if she has prolonged menses of 8 or more days, then she is also at risk for developing endometriosis. When this woman she presents with dysmenorrhea, dyspareunia, dysphagia. It is a characteristic triad of symptoms. Then we can think of endometriosis. We need to have this in mind. Endometriosis, the symptoms depends upon the site of lesion. The possible sites includes, the commonest one is the ovary. You can see it in the uterosacral ligament, round ligament, fallopian tube, cervix, uterus, bladder, vagina, rectum, intestine, ureter, lining of the pelvis, even colon. So the symptoms depends upon the parts which has been affected by the endometriotic lesions. So when the female reproductive tract gets involved, the woman may present with either pre and post-menstrual spotting. She can have cyclic pelvic pain. She may present with low sacral back pain, for which she most commonly enter the orthopedic. This low sacral back pain is especially most commonly seen premenstrually. And the most important thing, most distressing about endometriosis is that it is most commonly associated with infertility. She may have oligomenorrhea, she can have ovulatory pain, and even mid-cycle vaginal bleeding. When the bladder gets involved, she can have cyclic hematuria or dysuria. In severe cases, even she can go in for ureteric obstruction. When the rectosigmoid colon is affected, she may present with premenstrual tenesmus or diarrhea. Even in severe lesion, she can go in for obstruction. When lungs are involved, she can have chest pain, catamenial chest pain, even hemoptysis. Okay, the woman presents with following symptoms. What we have to do next? We do a bimanual pelvic examination thoroughly. If you are able to demonstrate tenderness or nodularity can be seen on the posterior vaginal fornix, can be seen over the uterosacral ligaments, then we can possibly think possibility of endometriosis. The ovaries may be enlarged and cystic. The adnexal structures may be fixed, will not be able to move. Even the uterus may become retroflexed due to dense adhesions. Then we can think of the possibility of endometriosis. We may be able to demonstrate in these things in a severe case of endometriosis. In the episiotomy wound or in the cesarean section scars, we'll be able to see tender mass over the scars. So these are the signs which we look out if we suspect endometriosis. After doing bimanual pelvic examination, we cannot just jump into a conclusion of endometriosis, but we need to rule out other causes such as the dermoid cyst, the hemorrhagic cyst, which is most commonly misinterpreted interpreted as endometriosis, endometrioma. Here, but the hemorrhagic cysts, they have high levels of internal echoes with thin walled cysts, and the hemorrhagic cyst usually resolves with time. Other cystic neoplasm needs to be ruled out. Coming to the diagnosis proper, the diagnosis of suspected endometriosis requires history, examination, and various imaging studies. But the gold standard for diagnosis is direct visualization at laparoscopy and histological confirmation. So, role of some biomarkers will also be elucidated. The ESHA guidelines 2013, they recommend transvaginal sonography with bowel preparation. And transrectal ultrasonography can also be done to detect deep infiltrating lesions affecting the bowel, bladder, and the rectovaginal pouch. Transrectal, a word about this transrectal ultrasound, which has very good meaning in doing in a women with endometriosis. It can be done even in adolescents. It has a better resolution. It has a very good diagnostic accuracy. Since it has restricted field of visualization, the distal bowel can be imaged properly. The deposits usually appear as round hypoechoic. If the bowel has been infiltrated, it can be seen as thickening of muscularis propria. The sensitivity is 97% and the specificity is 89% for rectal lesions and is much better than MRI. And if you add Doppler to this, the diagnostic accuracy is enhanced. The pericystic flow with the resistor index more than 0.45, it indicates low resistance waveform. Coming to the next modality, which is MRI. MRI has the advantage of imaging the entire pelvis in multiple planes. And it is most particularly useful in evaluating rectum and cul-de-sac. The appearance in the MRI depends upon the iron content, the proteins, and the products of blood degradation in it, in the lesions. Coming to the further differential diagnosis, we have to rule out whether the woman is suffering from chronic pelvic inflammatory disease or recurrent acute salpingitis. Hemorrhagic corpus luteum and ectopic pregnancy should also be ruled out. Benign or malignant ovarian neoplasm in case of endometriomas should also be ruled out. So, as I have said, diagnosis is by taking proper history and doing a good examination, a very good bimanual pelvic examination, doing a pelvic ultrasonogram. The gold standard is by the confirmation, is by the direct visualization of endometriotic lesion and confirming it by biopsy. Hence, as you can see, endometriosis in itself is not a clinical diagnosis. You can suspect in an afebrile patient if she presents with a characteristic triad of she has got pelvic pain, if you are able to demonstrate firm, fixed, tender adnexal mass, or if you are able to demonstrate tender nodularity in cul-de-sac and uterosacral ligament, then we can suspect her to suffer from endometriosis. CA 125, as we all know, it's frequently done and it is frequently elevated in women with endometriosis. But the sensitivity is only 20 to 30%. Hence, it is not used to diagnose endometriosis. Hence, the definitive diagnosis is generally made by the characteristic gross visualization of the lesion and confirming it by histopathological examination. These are done by either by laparoscopy or laparotomy, but laparoscopy is the gold standard. A word about diagnosis is that in this recent ASUOG, a French doctor presented a paper in which he said that detecting microscopic RNA 3 or 5 copies in the saliva, they are able to diagnose endometriosis. It is on further research and it has been approved there. Unless it has been well acknowledged over the world, maybe in the future, it may become a diagnostic tool to diagnose endometriosis rather than doing an invasive test. In India, I also heard that they are doing this microscopic RNA assay in peripheral smear. So this research is still going on. About this MRA protocols, MRA, they give a very good view about the borders, size, and the uterine symmetry, and about the maximal junctional zone thickness to the myometrial thickness. And they are able to identify high intensity spots within this myometrium. These are more characteristic for adenomyosis. These are some of the pictures which depicts endometriosis. It is an HSD done for women with adenomyosis. Here a CT scan has been done. Here an MRA has been done. They shows cystic areas surrounded by low signal intensity ring. This arrow mark shows it. This also the lesions. They show this, the uterus, they show this increase in the thickness of the junctional zone. This here is a picture showing an chocolate cyst, bilateral chocolate cyst, which has also been demonstrated by this MRA. And these have been proved by laparoscopy. These are also some of the pictures which depicts this endometric lesions in the rectovaginal pouch, in the ovarian cyst, everything. So we do a laparoscopy. And what do endometriosis lesions look like? What we look for? The classic lesions, they are red, dark brown, dark blue, or black peritoneal implants. We all know about the chocolate cysts of the ovary, appearance of the ovary. Sometimes these endometritic lesions, they can appear as clear vesicles. They may appear as white or yellow spots or nodules. The peritoneum, they may be appearing normal if there is only microscopic involvement. But in the later stage, they may appear as powder burn implants because of thickening and due to the scarred perilesional peritoneum. Coming to the staging of endometriosis. So we know endometriosis affects almost all the pelvic organs. Staging, why staging has been done? The staging has been done by the American Society of Reproductive Medicine. They employ a staging protocol mainly to correlate the fertility potential with a quantified stage of endometriosis. So the staging protocol is mainly to assess the fertility potential of the women. The staging was initially based on the site of involvement and the extent of the visualized disease. But now it is modified to include the description of the color of the lesions. So it will say whether it is early or late, that is older one or newer one. It also includes the percentage of surface involved in each lesion type, that is whether it is superficial or deep. And it also gives a more detailed description of any endometriosis, that is if they have any adhesions, severe adhesions present or not. By this, it has been classified into minimal lesion, mild lesion, moderate lesion, or severe lesion, depending on the site, number of sites involved, number of lesions present, presence of adhesions, number of organs affected. By this, they classified into stage 1, stage 2, stage 3, and stage 4. And these are given various points. According to the points, the stage 1, which is a minimal disease, with 1 to 5 points, and stage 2 is mild with 6 to 15 points, and stage 3 is moderate with 16 to 40 points, and stage 4, which is severe, with more than 40 points. So extensive involvement. Coming to so we have an overview about this pathogenesis of endometriosis and the symptoms with which the women present with. Now coming to the treatment. So we know the symptoms are distressing and they need to be treated. Endometriosis, one thing we should have it in mind is that endometriosis should be viewed as a chronic progressive disorder. and it is characterized mainly by the presence of pain, and its association with infertility makes it to need to be treated. The treatment, it requires individualized management. The goal should be to minimize repeated surgical procedures, and we should take into account the women preferences, her age, her presenting symptomatology, and the presence of infertility. The current modalities are the medical management, which includes the non-hormonal treatment as well as the hormonal treatment, and comes the surgical treatment, a combination of the both. Nowadays, radiological treatment is also given to these women. If you are able to, if you are finding smaller lesions when you do a laparoscopy for even for appendectomy or some other procedure, and the lesions are very small and the women have very minimal symptoms or no symptoms, then these patients, they doesn't need to get treated, but they need to be observed and they need to be examined every 6 months. Most of the endometriotic pain, patient come with pain. Here, the pain is mild and they have very small lesions. They can be treated with simple analgesics. The prostaglandin inhibitors like naproxen and ibuprofen, most commonly given for pain and menorrhagia. Coming to this hormonal treatment, the hormonal dependence of this ectopic endometrial tissue, they have provided the basis for the medical management of endometriosis. When do we need to give hormonal treatment? If the symptoms are severe, even though the pelvic lesions are small, but the symptoms are severe and the pain is not getting relieved by simple analgesics, then we need to put her on hormonal treatment. We do a conservative surgery, but still the women has recurrence of symptoms, then we need to put her on hormonal treatment. Sometimes the hormonal treatment may be given even before surgery for a short time, 6 to 12 weeks, to make dissection easier. But after conservative surgery, we have done a conservative surgery. Usually put her on hormonal treatment to allow any residual lesion to regress. If the woman doesn't opt for surgery, or if she is not fit enough to undergo surgery, then also we can put her on hormonal treatment. Treating a pain is not simple, as we all know. Pain can be real one or neuropathic one, or even with psychiatric. See, these women, when we treat her, treating a woman with endometriosis is really a nightmare for both doctor as well as the patient. She has to be counseled thoroughly. See, we are not confirmed the diagnosis, but we presume her to be suffering from endometriosis. So we need to counsel her thoroughly, and then we empirically treat them with adequate analgesia or the hormonal treatment like combined oral contraceptives or progestogens. When you put her on hormonal treatment or these drugs, we have to take into consideration the patient preferences. You have to know about the side effect of the drug which you are going to use. The efficacy is important, the cost and the availability, because we need to give it for long term. It's a chronic disease. So we need to know about the cost and the availability in our area. Hormonal contraceptive, most commonly the combined oral contraceptives which are used, they reduce this endometriosis associated dyspareunia, dysmenorrhea, even the non-menstrual pain. But they have to be continuously used in women suffering from endometriosis associated dysmenorrhea. They can be considered to be given as vaginal contraceptive ring or transdermal patch, but these are not much common in our place. Coming to this progestogens and the antiprogestogens, the most common drugs, medroxyprogesterone acetate, Dynogest, cyproterone acetate, norethistyrone acetate, or danazol. These are the drugs which are commonly used. The antiprogestogens like gestrinone can be as one of the options to reduce this endometriosis associated pain. So we are using both progestogens as well as antiprogestogens. There is various theories to explain this. dose. When you use progestogens, the important thing is that it needs to be given continuously. Not just supplementing in the luteal phase is not effective. The various preparations include the medroxyprogesterone acetate given as a dose of 30 milligram per day, that is maximum dose. The depomedroxyprogesterone 150 milligram can be given either monthly or once in 3 months. Norethistyrone acetate can be given in the dose of 10 to 20 milligram per day. The dydrogesterone can be given as dose of 20 milligram per day. Or the Dynogest, which is nowadays commonly used, can be used given in the dose of 2 milligram per day. Coming to the second line of management, it is most commonly used is the GnRH analogs and the levonorgestrel releasing intrauterine system. When we use progestogens, there are many add-back daily hormone regimens. They are added to avoid this estrogenic side effect. So they added hypoestrogenic side effects. So we need to add conjugated equine estrogen to medroxyprogesterone acetate or to norethindrone acetate. Norethindrone acetate, medroxyprogesterone acetate, or you can add etodronate to these. We have various estrogen progesterone combinations containing Dynogest, cyproterone acetate, desogestrel, various drugs. Even tibolone and the biphosphonates, etodronate, may be given to this because they are put on long-term on these drugs. They may have decrease in bone density. So to prevent that, they can be put on tibolone, or even biphosphonates can be prescribed in this perimenopausal treatment. Coming to this aromatase inhibitors. Aromatase inhibitors, we all know about this letrozole, anastrozole, desmontazone. They have found that in this endometriotic lesions, the activity of the P450 cytochrome oxidase is higher. These cause the increased production in the estrogen locally. Hence, these aromatase inhibitors, these drugs, they can be used in these women, and most commonly in women with rectovaginal endometriosis, which does not respond easily to other drugs. Or if the women, they are refractory to other drugs or the medical or surgical treatment, then these women can be put on aromatase inhibitors. Aromatase inhibitors, they can also be combined with, even if the women is taking combined oral contraceptives, progestogens, or even GnRH analogs, because they help to reduce endometriosis associated pain. But there's not much popular because of the cost. Coming to the analgesics proper, NSAIDs, other analgesics can be used to reduce endometriosis associated pain. These drugs are useful in women who are trying to conceive. Drugs like ibuprofen, naproxen, mefenamic acid can be given. The important thing is that needs to be started 2 days before menstruation, and all these drugs, they have the similar efficacy. Other group of analgesics like the cyclooxygenase 2, which includes the Celebrex or Vioxx, they are not much more effective than naproxen or brufen, but they have lower risk of gastric ulceration, and its high cost limits its use. There are various other modalities to treat or alleviate pain. This includes neuromodulators and neuropathic pain treatments. They offer a great choice of amitriptyline, duloxetine, gabapentin, or pregabalin. They can be given as initial treatment for treating this neuropathic pain. Sometimes the men may need drugs to reduce the central sensitization. As such, tricyclics and anti-epileptics may be needed to given. Hence, these women need to have a multidisciplinary approach. They can be even prescribed physiotherapy, as these women are most commonly stressed and depressed. Psychological therapy is a must for most of these women. Coming to the new oral medications and clinical trials. So endometriosis is still not understood properly, and there is no single drug that can cure endometriosis. And we have to counsel the women that it can never be cured, but controlled. That no researches are going on. And we have a word about the new oral medications. In the summer of 2018, the FDA has approved the first oral gonadotropin releasing hormone antagonist, which is called elagolix, to help with moderate to severe pain from endometriosis. Elagolix is a daily pill. It works by stopping the production of estrogen. As you all know, estrogen contributes to the growth of endometrial scarring and uncomfortable symptoms. Two more oral GnRH antagonists like linsogolix and relugolix are currently being studied in clinical trials for treating endometriosis pain. Another clinical trial is underway to assess the use of dichloroacetate for treating endometriosis. This drug is currently used to treat metabolic disorders in children. Preliminary data has shown that DCA could help stop the growth and survival of endometriosis cells, and they help to reduce lactate production, which is higher in women with endometriosis. Even cannabis has been tried, and a 2020 study has found that 59% of women who reported using cannabis for endometriosis relief, they were able to stop relying on pain medications, including opioids. This is done in the foreign. And this may be related to the increasing evidence that the cannabinoids, they help restore imbalances in the endocannabinoid system, which are thought to contribute to endometriosis symptoms. Pelvic floor physical therapy award. It is nowadays increasing in popularity among those with endometriosis. The research from a 2021 study, they have found that doing a pelvic floor physical exercise regularly, they can help reduce endometriosis symptoms like this painful sex and pelvic pain, and they help to improve pelvic relaxation in women with the condition. We are giving hormone treatment. How does they act? These drugs, the combined oral contraceptives or the progestogens, they put the mother in a state of pseudo-pregnancy by inhibiting the ovulation and menstruations. They can be inhibited for between 6 to 18 months, most commonly for 9 months. The OCP, sometimes progestogen alone may be given to avoid the estrogenic side effects. The combined oral contraceptive tablet, if it needs to be given daily. If medroxyprogesterone acetate is given, it can be given at a dose of 10 to 30 milligram daily. Just giving an example. The side effects of progestogens, they include headache, weight gain, fluid retention, breakthrough bleeding, and depression. Coming to this next drug, danazol, which was used widely before. Now it has restricted. It has been restricted. There is restricted use of danazol. It is usually given orally 400 to 800 milligram per day for 6 to 9 months. It has a very good potential in relieving the pain. It is a weak synthetic androgen, but its androgenic side effects such as acne, male alopecia, hirsutism, hoarseness of voice, and hypertrophy of clitoris restricts its use. It also has other side effects like hypoestrogenic effects, anabolic effects, metabolic effects, CNS symptoms, GIT symptoms, musculoskeletal symptoms like muscle cramps and swelling of joints. Even hematuria may be present in these women who is put on danazol. But still, there are persons who are fond of giving danazol for these women. Coming to this GnRH analogs, the agonists, their initial stimulation, when they are given initially, they cause increased FSH and LH. Later, prolonged stimulation, it results in receptor desensitization. Hence, there is decreased FSH and LH, thus creating a reversible pseudomenopause in these women. Important thing is that these drugs cannot be given orally. These drugs, naphylene or busulfane, it's given intravenously using a nasal spray, about 200 micrograms twice daily. Goserelin, leuprolide, they are given as 3.6 milligram injections subcutaneous every 4 weeks. Triptorelin is given as injection of 3.7 milligram injected IM every 4 weeks. That is once in a month. The side effects includes hot flushes, dryness of the vagina, dyspareunia, and reduced libido. Even there is decrease in bone density. So having an idea about this medical treatment, if it fails, what happens when hormonal therapy fails or the lesions are large, then we need to go in for surgical treatment. Surgical treatment, as we all know, is either conservative or radical. Most commonly, it needs to be conservative. Conservative surgery is almost for the young patients below 40 years, always for young patients below 40 years. Various conservative surgeries like pre-sacral neurectomy has been previously done to treat severe dysmenorrhea, but it has to be meticulously done. Nowadays, these minimal to mild lesions, they can just be removed by laser or electrocautery. About this radical surgery, usually done for women above 40 years. What we do is just do a total hysterectomy and bilateral salpingo-oophorectomy, which is really very tough in these women with endometriosis. I'm just giving a short guideline for a woman who is endometriotic with infertility. Here, I'm just giving a basic guidelines. That is, that if this woman with endometriosis, if she is infertile, giving hormonal treatment for suppression of ovarian function to improve fertility should not be prescribed. If she suffers from stage 1 or 2 endometriosis, we do an operative laparoscopy. Just doing an operative laparoscopy for diagnosis is not enough. We need to do adhesiolysis and do definitive procedure, excision or ablations. Then only this ongoing pregnancy rate will be improved. In these women, CO2 laser vaporization is better than monopolar electrocoagulation. If you do a laparoscopy for ovarian endometrioma, you have to do excision of the endometrioma capsule. Just doing a drainage and electrocoagulation should never be done. In women with stage 3 or stage 4 endometriosis, you have to do operative laparoscopy. You need not to wait. No expectant management can be performed. And if these women who have stage 1 or 2 endometriosis, the clinicians, they can perform intrauterine insemination with controlled ovarian stimulation instead of expectant management, as it increases the live birth rates. Sorry. The use of assisted reproductive technologies should never be deferred. It can be even started if the tubal function is compromised or there is male factor infertility or other treatments are failed. So you should not restrict them. If them needs to be put on assisted reproductive technology, immediately put them on. These are pictures showing this laparoscopic surgery, removal of endometriosis, discarding, dissection of endometrium. What we need to know is that you should refer a woman with suspected or diagnosed deep endometriosis to a center of expertise. See, it needs to offer all available treatment in a multidisciplinary context. You cannot just do a surgery and send her. She needs to have a multidisciplinary approach. So just doing a laparoscopic excision of endometrioma and simply leave. No, the women needs a careful follow, and she may need to be put on hormonal therapy. So the person, the facility is available, and the person who has the knowledge of treating her should do this surgery. About this current role of robotic surgery. This robotic surgery is nowadays gaining popularity in surgery. Although it is safe and there is no statistically significant differences found in the operative time and in the peri and post-operative complications, and still there is lack of information in the literature. And it is also a higher direct cost of healthcare. And there is no tactile feedback when we use this robotic console. The scarcity of literature on the grade of lateral heat spread is also still not there. But The faster learning curve of robotic surgery may facilitate the spread of minimally invasive surgery. The technical advances may potentially improve the surgical performance, and they may decrease the perioperative morbidity and the risk of laparoconversions. So robotic surgery in future may help in treating these women. A word about this radiological treatment. Here, we induce artificial menopause by giving external pelvic radiation. It cures the condition by causing atrophy of this endometrial tissue. Hence, it can be applied only in patients above 40 in whom operation cannot be done, as in the case of widespread pelvic endometriosis, which is commonly called as frozen pelvis, or endometriosis of the deep-seated lesions such as the rectovaginal septum, which is difficult to excise surgically. There are various other modalities which are nowadays coming to treat these women with endometriosis. A study from Northwestern Medicine in 2018, they have discovered that the induced human pluripotent stem cells, they can be reprogrammed to transform into healthy replacement uterine cells. This means that these uterine cells, they causing this uterine pain or inflammation, can be replaced with healthy cells. Since these cells are created from the person's own supply of IPS, there is no risk for organ rejection. But more research is needed. But if there is potential for cell-based therapy, it can be potential for long-term solution to endometriosis. Next comes the gene therapy. Here, they suggest that the suppression of specific genes may play a part. And scientists at the Yale University, they published a study in 2018 that the microRNA LED7B, it is a genetic precursor that controls gene expression. But this gene is repressed in women with endometriosis. The solution, if we administer LED7B, it may help to treat the condition. And they have tried in mice, and it is promising. But more research is needed before testing in humans. Coming to this neuropeptide S receptor 1, it can be a non-hormonal treatment target in endometriosis. They have seen that DNA variations that produce the protein neuropeptide S receptor 1. It occurs more often in women with endometriosis compared to those without the condition. Hence, they found that this neuropeptide S receptor 1 play a role in endometriosis-related inflammation. Their drug they used to shut down this activity has been effective in mice, but still not approved in humans. If gene therapy does prove effective in humans, it could be a non-surgical, non-invasive, and non-hormonal way to treat endometriosis. So, as we know, it's a complex disease, it's an enigma, it's a nightmare, whatever we can call. What the key point we need to know is, it is a disease where tissue similar to the lining of the uterus grows outside the uterus, causing pain and most commonly infertility. It affects globally about 10% of reproductive age women and girls. You have to know it is a chronic disease and it is associated with severe life-impacting pain during periods, sexual intercourse, during bowel movements, and during urination. She can present with chronic pelvic pain, abdominal bloating, can suffer from nausea, fatigue, most often depression, anxiety, and most often infertility. These variable and broad symptoms of endometriosis, it means that the health workers do not easily diagnose it, and many individuals suffer from it. They have limited awareness of the condition. Hence, this can cause a lengthy delay between this onset of symptoms and diagnosis. At present, there is no known cure for endometriosis, and the treatment is usually aimed at controlling symptoms. Access to early diagnosis and effective treatment of endometriosis is important, but still it is limited in many settings, including the low and middle income countries. Hence, there is a need for more research. Need to have awareness around the world to ensure effective prevention, early diagnosis, and improved management of the disease. With this, I conclude this topic. I once again thank this Shield Healthcare for giving this opportunity to know about endometriosis. Thank you.
Thank you, ma'am. Thank you very much for that informative session, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants. If there is any queries in YouTube also, ma'am. If there is any queries, then I will read it for you, ma'am.
Okay.
Ma'am, I have one question like, what are the chances of recurrence, ma'am, and what will be the risk factor for this recurrence, ma'am?
Recurrent endometriosis is really difficult to treat. And recurrence is very, very, very common, even if you do a complete surgery. And even up to 15 to 25%, even 45% of these women, can have recurrent disease.
Okay, ma'am.
Since it's a chronic disease, think like that. It's a chronic disease. We are not going to cure the disease. We are just giving drugs to control the symptoms. Hence, recurrence is very, very common.
So, yeah, ma'am, if the recurrence is common, then out about this infertility treatment, ma'am, those patients with endometriosis and this infertility treatment.
It will be really difficult. But this with women with recurrent endometriosis, if they are suitable for assisted reproductive technologies, we can straight away go for that. This infertile women.
Yeah.
They can.
Yes, so what will be the range like? What is too thick, ma'am? What level is too thick for this endometriosis or that thickness? So we say that it 8 to 8 mm or 10 will be fine, but even if it is,
thickness, it depends on the site. If you think about adenomyosis, then it differs. There's thickness, this intensity means the myometrial thickness, that depends. Okay. So whether the lesions are superficial or deep, whether it gives adhesions, these all takes into account. Just the thickness, though, depends on the site of this lesion.
Okay. Fine. So delegates, if you have any queries, you can just raise your hands or you can just unmute and you can ask the speaker directly. If there is no queries, then we can end the webinar part. Ma'am, there is no queries in YouTube also, ma'am. If there is any queries, then we will be forwarding to your mail ID, ma'am. You can address all those queries, ma'am.
Okay.
Thank you, ma'am. Thank you for accepting the invitation and for being with us today, ma'am. Once again, it's an honor to hear you, ma'am. Thank you, ma'am. And we are looking for many more webinars with you in future too, ma'am.
Yeah. Thank you. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you very much.
Yeah.